strong convictions. Good morning, America.
Good morning.
We're all in our places with sunshiny faces. Guys, I'd like to call our meeting to order, so we're going to try to start on time and be respectful of everyone's time. Today, our meeting is going to be, as our last couple of meetings have been, a lot of input from the committee. We're coming down to the final actions of our committee, and so what we wanted to do today was ask Lori to come and just kind of walk us through the report. You've seen the draft. You've read the draft. Hello? Okay. And so some of it.
Seeing the draft is accurate.
Yeah, okay. And so what we want to do is make sure we're all on the same page before we walk out. So without further ado, Lori?
Yeah.
There you are.
And Dr. Bayshon is here too, so we're going to kind of tag team this as usual.
Tag team. That'll work.
Yeah, because people, you might start falling asleep if you just hear one voice.
Laura, if you would speak up so everybody can
Yes.
hear you and we're fully engaged.
Okay, is this better?
Yeah.
Is it picking it up? Okay, great. Okay, well, I wanted to start briefly by just saying what this document is and what it's not, and just frame it a little bit. So the primary audience is the Commissioners Court and the JPS Board of Managers. So certainly this report is appropriate for many other people who are interested in this topic, leaders in the community, CEOs of hospitals, heads of community-based organizations, public officials, and many others who express interest. But what it isn't is something that we would hand over to a typical citizen, to give them a little background on an issue that they might be voting on in the future, or just for information. So what we would probably do is have a couple of pages, and I think Ms. Miller is going to talk about this a little bit later, kind of a citizen's call to action and what we might prepare for a typical citizen to take a look at that's really accessible, that's in lay language. This is, somewhat. I mean, I think it describes things quite well, but it's 45 pages, and we can't hand out 45 pages to everybody. So a few weeks ago, HMA and Cumming presented our respective reports to the Commissioners Court. There were several folks from JPS there as well. But as we know, they wanted to engage citizens in this and in this process and produce a streamlined report from those two very large reports that speaks to findings and your recommendations as citizens of the county. So what I'd like to do, and I think some people have seen it, seen the report, and some people have actually read it. But before I start going through it section by section, I'd just like to ask overall if there were any particular comments, anything that struck anyone in terms of something that was missing, or in terms of something that was in there that you'd like not to see in there. Or kind of the balance or the respective weight of the different sections. Any kind of overall comments before we start walking through?
Guys, don't be shy. When they asked me, I kind of raised the issue shyly that it was kind of wordy.
Yes.
Yeah. That I try to look at it if the everyday citizen was reading this, Pastor. Would they read it? And how do we quickly get to the points that we want to make? But I think they've worked on that because it was 60-something pages. Now we're down to 45. Was it 60 or?
No, it's been about this length.
Okay.
Yeah. I mean, we could pull it back if we wanted to, for sure. I mean, it's up to you folks.
It's up to us, to the committee.
Well, I have a question. So excuse my ignorance on this, but when it comes to giving background information, especially back to the Commissioners Court, how much of that, as far as overall bullet points, or for instance, I'll give you an example. So somewhere in here it goes into the different sections of the community, and I think that they kind of know what their population is. So how can we communicate how it either directly affects you know, that precinct so that it makes sense to the reader. If we're talking to the commissioners, this is just me, I'd wanna know exactly in my precinct what this looks like from my constituents. I don't know if we could break it down like that. That's what I was kind of looking for. If we're in the lens of, now, I'm not a commissioner when I might be stepping out. Is that easier or is that helpful? To see the impact on your precinct, what that means to you?
Well, I can't speak for other commissioners, but
Okay.
for me, I have a pretty good perspective on the healthcare gaps in my precinct.
Okay,
There are a lot of reports,
okay.
not already, but I think from her standpoint, you're looking at a countywide,
Yeah.
because JPS serves countywide, right?
But if, to your point, Madam Chairwoman, if we're saying that for a layman, that's why I don't quite understand. If it's for me personally, while, yes, from a county perspective, overall, there should be some sort of executive summary, real quick bullet points overview. But as someone who lives in precinct 1, I wanna know exactly, well, what does that mean? How is this gonna affect me if my taxes are gonna go up? What's in it for me?
Well, that is, I think, part of the larger discussion we're gonna have after we go
Oh,
through
okay.
it.
Right.
Because
That sounds good.
that folds into what we hope our call to action will kind of look like.
Okay.
But right now, I think we have an excellent report. Now, I don't see any problems with it, and I think what Lori's trying to get to right now, among us committee members, among us chickens, is there anything that we think that ought to be passed?
Yeah, page 10, under Health System Transformation and Integration, there's at the end of the second paragraph, you state, the recommendations in this report related to sizing facilities for future need assume that healthcare delivery will be transformed and integrated over time and will decrease the need for acute care and psychiatric facilities. That seems contradictory to what we're asking for with an increase in psychiatric facilities. We're saying that over time the need is going to decrease. I thought that was kind of
The need per population will decrease, the population is
Yeah,
decreasing.
I would state that a
So
little
it's still
differently,
gonna-
because it
it's still gonna-
contradicts the recommendation
Well-
in the report.
Yes, and there's two pieces to that. One is that, on the psychiatric needs side, the needs aren't being met. So even if you're bringing the needs down, so one is the current needs aren't being met, and the other is over. And the other point is over time to be able to decrease those needs so that the growth of the population doesn't call for a undue amount of building.
Yeah, no, I get that, but
yeah.
You're just saying the
But I think
wording.
it's-
I got you.
think maybe
I
it's the
think
way it's written,
wording-wise, it
right?
contradicts what we're
Right,
recommending.
right, right.
And then, this is just a personal, I don't know, I read it and I thought it was probably unnecessary to be in there. You seem to be advocating for the increased minimum wage as a part of the social need and overall community health. I think that's a pretty politically explosive issue in Tarrant County. I don't know that that would be a wise sentence to include, frankly.
Where is that?
Did we actually put in?
Page 11.
Yeah, I did
Yeah,
see that.
it's in there as a,
Yeah, you talk about the social economic
Yeah.
as 40%,
as another,
contributing to the overall health outcome.
The
Yeah.
increased minimum wage
as
to
an,
match the local conditions of a living wage, along with what is essentially universal health coverage, can be seen as a locally appropriate ways to address economic impacts on health. Okay.
Yeah, and it
It's a ver-
uses
right.
San Francisco and Chicago are not Tarrant County.
Right.
And that may be a winning statement there, but I think it would not be here, frankly.
Okay.
What I think I read that statement, and I share the same concern as Mr. Fisher, but I think what you really meant was if we work to increase the income of those individuals, then their chances of having a better health outcome would also increase,
That's right.
because social economic condition affects 40% of
Yeah.
the overall health outcome, right? Okay, so there are many ways to get people to increase their income, to help people increase their income. It doesn't have to be a mandate for the federal government.
Correct.
For a minimum wage. It doesn't have to be that
Right,
way. It can
right.
be education, it can be
Right.
multiple ways to do so.
Yeah, I took it as you did, Commissioner, but then you
I mean, I don't disagree with what Andy said.
Yeah, no, that,
I
and
would
when I
state
read
it
it, that's what I
probably
did,
more.
yeah, yeah.
Stated a little more that direction than,
So we can change
Economic
that. to-
opportunities and
sure,
just.
educate,
Yeah.
all of that fits together.
Right, so it doesn't look like we're just advocating for an
yeah.
increased minimum wage. Got
Yeah.
it.
Thank you for raising that.
Do you want us to go into the details now? Do you want us to fly high?
No, no,
and
I
look
think
at the
she-
basics?
Yeah, I was asking to fly high at
Yeah,
this
and I
point.
think what he.
Fly high.
Yeah.
Okay,
Yeah.
okay, I just want to make sure.
Now, if there are some critical details that you think are kind of the editorial side, if you could talk to Lori and Peter, they'll work with you on that.
Yeah.
But
Yeah,
I think right
absolutely.
now, I think overall, we're trying to get a sense, are you happy with what do you feel personally comfortable with the report that we have here? Are there any
Well,
policy changes that you would like to?
From my perspective, I think this format is helpful for policymaker. We need the details because the devil is in the detail. We need the details, so sometime at the risk of being wordy, you have to spell out the intricacy of some of the challenges and the solution we have to execute. But for the consumption of the public and those who are considered stakeholders, I would recommend some sort of a scaled-down version
That's
using graphics.
Yes. Yeah.
Using illustrations,
Right.
maybe on a 4 to a 5-page brochure, trifold or quadfold.
Right,
In that methodology, I think it would be more effective to communicate the message.
right, exactly, and that's what we're going to dedicate
Yeah.
the second half of this
Second
meeting
half.
to.
Mr.
So-
Kelly?
Oh, did I have a
There's one
statement?
behind you.
Well, you had that query look on your face.
Well, mine is the same one I had last time, because as I read recommendations, I don't think there's any rationale behind the numbering system, but it appears we've numbered these in a non-sequential manner, as if these are 1, 2. And I know we finished last time saying we're making no recommendations in order, we're just saying we think on these things. I would suggest maybe dashes or something, eliminate the numbers.
Oh, okay,
Good
okay,
point.
gotcha.
It is good. I think one thing we also need to do is, we need to go through the report, and we can do this as staff, but, since we began writing this report, there's some additional information that's changed. For example, infant mortality rates, we just got some new numbers out, and our numbers in Tarrant County have improved substantially. And I know that we have a reference to that on page 15, we need to go back and change that, so it reflects the most current data. Second of all, I noticed that, and we talked a little bit at staff level, you talk about a population issue, I think you used 1.8 million. I know you pulled that from probably the last federal census or close to it. We're now, through the COG, we're over 2 million. And so we need to make sure that our statistical numbers are accurate in most of the days.
Okay.
Fact checking, basically, yeah, you've been doing some fact checking into that.
Yeah, we'll just do those updates. We can do that.
Madam Chair, I'm not a committee member, but I have a concern.
Okay. Will you let me just get the number and I'll come right back to you? Glad you're gonna have something to say. Okay.
I didn't see any dollars in here. Are we not gonna put dollars in here, or is that gonna become later? I mean,
Dollars are based in the coming report,
okay,
and which is an attachment to this report.
okay.
Thank you for bringing it up. 'Cause yes, sir. You got a mic.
Dennis Kelly, I'm looking at page 47, the construction schedule. And, okay, our precinct was really concerned, and I think a lot of the citizens are concerned about behavioral health. And if you look at the chart, behavioral health is the last thing that gets executed on the schedule. That makes no sense at all. In fact, behavioral health, this construction should be going on right now. The hospital has the money to do it. They need to start building on behavioral health right now. It's not a great deal of money, and it's needed from a community standpoint.
Right. I mean, I could speak to that a second unless you want to speak to it, Scott, or?
No, please.
Okay. So behavioral health, the best thing we can do for behavioral health right now is to have outpatient, community-based behavioral health services. And that's being integrated into current community health centers that JPS has and the ones that are planned for the next few years. So there are 4 community health centers that are planned, in 4 different areas of the county. So that will help. Another major recommendation is for JPS to lead a countywide behavioral health plan with others that provide behavioral health to look at a number of different areas related to behavioral health. So I wouldn't say that we're waiting until year 4 or so to address behavioral health. I think it's being addressed right now.
If you're going to sell this plan to the public, this is a big line item for the public, and
Absolutely.
the faster you can execute on this and say you're going to execute, the more chance you have of selling it to the public.
Yep, I hear
And
you.
you're not doing it with this chart.
Right, I hear you. That's for the facilities. It might make sense for us to kind of go back to the drawing board a little bit and talk a little bit more about some of the major planning efforts and partnerships and that kind of thing, and when that might happen. There's a workforce initiative, a behavioral health community-based initiative, so that might help
So you
sell
don't
things as
think
well.
that the 4 clinics that we're hoping to get done online that will include behavioral health will help?
The key word is hoping. We've been hoping for a long time,
Okay.
and it hasn't executed within the system. It's just not there. It's not there with the quality that it needs to be.
Yeah, okay.
And I don't think it's going to be there. You need
Even in the clinics?
Yes.
I think it was a way of trying to address the immediacy of it, but
I'm not an advocate for it. I'm just saying that if the public is concerned about this issue,
Okay.
real concern.
And I think what the committee hopes to do is that, yes, we will, or GK and the commissioners will work aggressively and the board of managers to make sure we do have a behavioral hospital.
It's a small line item as far as cash is concerned, but it's a big issue.
Well, I think it's a big issue for this committee also. I think we're all unanimous. Pastor?
Yeah, I agree with that. The only reason I didn't have a problem with it is because as I looked at what was being constructed, parking garage is first, you need that. Then, in regard to the new tower, you're going to build that, but actually the behavioral hospital comes in the second quarter of the same year of the building of the tower. So that's 4 months. It's a 4-month difference. One of the things that, and Dennis and I went precinct 2, one of the things that we are definitely pressing on, and we've seen, and I think the committee has attempted to address, is the need for those behavioral health services to take place in those smaller centers. And that is being addressed. But I'm, just having built things before, in my profession, 2 quarters, that's not bad. You can't build them at the same time, I don't think. Somebody can speak to that if I'm wrong.
Comment on that a little bit.
Yeah,
I mean,
it says
some of
succession.
the timing of what you do has to do with your site.
Yeah.
Where buildings are and what you're gonna do with what. So, your consultants have to go through in the implementation phase. They have to figure out it, because you're working at a hospital that's being used.
Yeah.
So you're building things, moving patients, so there's an order that has to take place that maybe I'm going to speak about, that is just a function of what you're gonna do on the site and when you're gonna do it.
Yeah, it's hard to beat that.
Committee,
But we do
we're
need
still in
services.
consensus on the
Yes, we do.
timing that we're seeing here. We still feel pretty comfortable with it? Okay. Carl? You're on the board of managers, so you feel comfortable with it?
I have a statement to make that has nothing to do with this, but it's
Okay.
part of this that I have a feeling about. Is now okay?
Now is okay.
Okay. On behalf of organized medicine and as a physician myself, I take exception to the discussion on page 12 of the current trend is to shift payments from traditional volume-based payment snarl, as exemplified by fee-for-service payments snarl, to payments that are more closely aligned with value, smile, cheer, and applause. So On behalf of organized medicine, I have never based my care, nor do I have many colleagues who base their care purely on volume-based payments. And to say that value has suddenly been discovered is also a very naive concept. You get my drift?
Yes, we do.
We've had terminology in the time I've been in medicine, and before, when Medicare came along, I said, oh my God, it's ruination of medicine. But for what it's worth, stating that the standard is changing, yes, we all see that it's changing, but I just sort of take exception to the fact that I've always been out there for volume-based payments in my career, which couldn't be further from the truth. Thank you for allowing that paid political moment.
Okay, Roy.
We could do some changing of that. We could talk about alternative
Yeah.
payment methodologies or that reward value based on, or reward health outcomes, patient experience, could
That
frame
phrase
it that
may
way.
have been driven by some of your other
definitely
colleagues.
in the lexicon now,
Thank you.
value-based, so.
Okay.
I agree with what you are saying. I also, there's two pieces to it, and one is when you have certain economic drivers over a whole system, that
Right.
there is at least some shift among some that are practicing in that environment, and there's some shift there. I think we, may want to capture some of those concepts a little more strongly.
Or just talk about what is incentivized now, right?
Okay. Yes,
Just
sir.
a point to follow up on Dennis's statement, and I do think we can get in the weeds quickly when it comes to how the citizens would perceive a report like this. I think if we can broadly illuminate the phases of construction that are really relative to the major elements of construction, it's very clear here that what we intend to do is within that first phase, the parking garage, the tower, and behavioral health are priority one. And I'm not sure that we gain anything by trying to differentiate that by quarters, because it does appear that all of a sudden behavioral health now becomes a third priority, and it's not.
Yeah.
And I think we may just want to synthesize
That's just a graphical.
that discussion
Yeah.
and try to make it much more broad and eliminate that concern completely, because it's really not the intent.
Yep.
That third priority.
All right. Great. Any other observations, committee members, that you may have that you want to raise with Laura before she just gently, at a 90,000-foot level, kind of walk us through what the report is actually? Anyone else? Well, thank you for that. At least that says that we've observed, we're great observers of the process here. Lori?
Okay, so let's just take a walk through each of the sections, and I'll stop after each section and see if there are any comments based on the highlights that I touch on. So starting on the executive summary on page 2. So we talk about the establishment of the Citizens Blue Ribbon Committee, when you were convened, what you reviewed, national trends, themes of stakeholder engagement processes, population projections, that you toured the facilities, that you studied the implications of those population projections on those facilities, and that you were looking to approach the county's health system in a holistic manner to decrease overall cost of the system, and looking at cross-sector strategies as well, including workforce issues and other strategies to reduce preventable and costly healthcare utilization. Thoughts about the executive summary? I particularly think it's one of the weakest parts of the report, and that it will probably be read by many and the rest of the report read by fewer, and that we can strengthen this a bit. So I have some ideas on ways to do that, but any thoughts on the executive summary?
Okay.
And this is a minute detail. There's a statement in there. It says, I believe it's on page 2 of the executive summary. It said, we acknowledge the implications of population projections on primary care and community-based behavioral health care capacity, and in particular, the opportunities in behavioral health care. That makes us a little bit opportunistic. Maybe change that to needs or something like
Commissioner, what paragraph is that in?
Okay, it's right in the middle, it's the fourth paragraph.
Okay.
Yeah, I think that's awkwardly written, and so I had that down to reword. But I
Okay.
agree with your, we can change opportunities to need if we,
And back to Mark's point earlier about reviewing financially funding, and I think it's important somewhere in there to say that our charge wasn't to allocate the dollars. That's the Commissioner's Court, or however you want to say it, but
right.
it's noticeably absent here, and either we missed it or we weren't supposed to do it. I'd rather just say we weren't supposed to do that. So.
Right. I do have later on what the charge was, and it doesn't include anything related to
Well, that's
to
an absence
finances.
of, but with
Right,
it not
right,
there,
exactly.
you're
I can
still
more
wondering
actively
why.
say that.
Yeah.
No, I agree with you.
And probably to say it up front.
Yeah, I think in the executive summary, it might be useful to say it
Oh,
there.
okay,
Yeah.
gotcha.
So no one's looking for numbers in this report.
Yep,
That's a
yep,
good point.
Yeah, good,
okay. Got it,
Thank
thank you.
okay.
As we can tell, may I add, is really the charge of this committee is to assess the healthcare needs of Tarrant County and the potential solutions for the future. It's not really about vetting a bond package.
Right.
But it has been framed initially as such by multiple parties within the county, so it leads to a confusion. But now looking at the end product is really, is a charge to assess the healthcare needs of Tarrant County.
The future healthcare needs, yep. Right.
Okay. I don't think there's any need to go through the introduction. I think it's just a quick background. So then we go into the background section, which is page 5. Talk about the JPS Health Network to give people a little bit of background on that. We talk about background analysis and reports. So there is just to put this report in the context of a long history of deliberations. And then the third section in background is the Citizens Blue Ribbon Committee, and it talks about the committee being appointed, convened, what its charge is, the membership, the co-chairs, the meetings, and the deliberation process, including approach to voting on recommendations, and that you will present this report to the Commissioners Court and the Board of Managers this year.
Lori, one observation is we tend to use the word hospital in the report to indicate the JPS Healthcare Network. And we've had this discussion multiple times at the board level, that if people get the perception that our efforts are to a hospital, then there's a huge piece missing. And when we start talking about the community impact and the clinics and the other things that really make up our charge and I think our function relative to this
You don't have to
package.
convince me. I mean, if I did that, it was a total oversight.
It's
So
right in your introduction, in your first sentence. And I would like to see that, the responsibilities of county hospital
oh, is it
changed.
the hospital district? Is that what you're saying?
Yeah, or healthcare network.
Oh, the healthcare network.
Yeah, the healthcare network, I think, gives it a more global look, because I don't want to lead off with the notion that this is about a hospital.
Right, exactly. So we'll get out the hospital district. Is that what you're
Yeah,
saying?
that'd
Because
be
I don't think we
fine.
ever referred to JPS as a
District or
hospital, but
network?
the hospital district.
Because we're JPS connected.
What is the recommended terminology that the board uses?
I don't know if we've ever picked one, Scott or Roy.
I've always had it as JPS Health Network.
Yeah, health network is what we tend to use
Okay.
just in terms of nomenclature at the board level. We
Yep.
rarely refer to ourselves as a hospital.
So we're going to refer to it as health.
Yeah,
And I think
JPS
you
Health Network.
I
and
think we
I
have
do
to
that.
stick with that, because if you don't, then people will pick up hospital
Yeah,
and
that
use
was-
it. And that's not what you want. You want folks to see that this is a network, it's a interconnected
Absolutely.
system.
Absolutely.
Yep. Okay.
Okay, so we'll do a search for that, for the hospital district, because I don't think we did it anywhere else except in the frame of hospital district. Okay, anything else on background? Okay, let's move on to national trends in healthcare and relevance to Tarrant County. So we talk about the culture of health, kind of a multi-sector effort. We talked a little bit about what Commissioner Wynn mentioned before, that actual health care only drives about 10% of health outcomes, that health behaviors drive 40%, that socioeconomic factors determine another 40%, that physical environment contribute to the remaining 10%, and that a culture of health calls for all sectors to engage in improving population health.
Can I ask you a question about that?
Yes,
You cited some of the research
yeah.
here. How valid are those researches? Are they widely accepted in the healthcare industry that these are
Yes.
highly credentialed?
Yeah, they are. Actually, the first bit of this research, the foundational research, was done by McGinnis and Fogey, but it was replicated more recently and published in the American Medical Association Journal. So that's the kind of socioeconomic factors, behavioral factors. So, and then the Wisconsin Public Health and Health Policy Institute is another one. This is widely recognized. You know, is it perfect? You know, is it exactly 40%, 40%, 30%? You know, we can't say, but I think these are good ballparks, and this is what's generally accepted in the in the field.
I mean, looking at the information about the Wisconsin Public Health and Health Policy, it basically states that actual health care drives only 10% of the health outcome. The rest of them, 90%, depends on the determinants, their behavior, the social economic condition, and the environmental physical quality, right?
Exactly.
In much of our report, the focus has been on building buildings to basically provide healthcare service. So we've been focusing on the 10%.
Well,
The
we
90%.
have a lot of other recommendations, right?
Okay. But I want to see, it's the tendency for a human being like myself to focus on big shiny objects, tiny lightly. And I just want to drive the point, is the key to a successful outcome is in the intangible. It is not the tangible. I just want to make that statement, if I may. And also, one of the things you mentioned in that report, the physical environment, which includes important factors as air, water quality, housing, and so forth. If it's okay, you may want to talk to our public health director about highways and how highways, I-35 and so forth, creates barriers and basically becoming an obstacle to a good health outcome for our community members as well. And in Texas, highway is very, it can become much more, a bigger footprint in the community. So when it comes to planning highways and things like that, that is a part of the overall solution. Yeah, it's not mentioned in there. So.
No, I didn't put highways in there. I was citing other research, but it's interesting because there are, health impact, statements that are often developed or with increasing prevalence in communities when something like a highway is put through. They talk about what is the health impact of this, what is the health impact of, whatever it might be. But that's something that I think needs to be in the mind of policymakers and planners and
The reason
others.
I say this is at the Tarrant County, the Commissioner's Court, we are highly focused on transportation solutions. If you ask many of the court members what are their number one priority, they would tell you it's transportation. Okay, so being able to understand the link between transportation planning and healthcare planning, I think we have to make that a determination.
Okay, we'll take a look at that and see how we can weave that in. Let's move on to health system transformation and integration. So we talk about different models of health and how we started out kind of traditionally in an acute care system of episodic, non-integrated care. So each health facility or system working independently, our providers, our patients or whoever comes to see us when they're sick, and we patch them up and send them on their way. So looking at a continuum all the way to systems that are connected with one another, that care is coordinated for patients that different systems touch, that entities really focus on a population of patients and they strive to keep them healthy. They focus on prevention and preventive care. So we talk a bit about that here. A next theme is whole person care. So often we have primary care provider that's taking care of a body and a behavioral health provider that's taking care of a mind, and social services that take care of other things. So what we're talking about is integration here. So having physical, behavioral, oral health, social services in a health center that's integrated. And further, looking at care management for those folks that have particularly complex conditions or multiple chronic conditions, and making sure that we're not just dealing with that patient's diabetes, but that we're also looking at that patient's poorly treated depression or lack of transportation for medical appointments or their inability to buy food or what have you. So looking at that type of integration as well. We move on and talk about value-based payment and how care is currently incentivized and how over time it's being incentivized differently. A continuum of payments that are alternative to our historic payment system that focused on fee-for-service, and how that requires delivery systems to change.
Can you clarify one statement for me on page 12? In the second paragraph, the last sentence of the second paragraph, it said, in these models, the healthcare providers get a payment that is independent of the amount of services that are delivered, and improvements in care delivery and outcomes result in significant financial gains.
So
What
that's.
does that mean?
Yeah, so that's talking about changing to a population-based payment, which various entities do take, like managed care organizations, where they're taking a per member, per month payment for the total care for that population. And if they manage that well, they get some gains. This is talking about bringing that type of payment to provider organizations as part of the continuum of value-based payment. So an example is Maryland, where hospitals get a global budget. You get $100 million or $500 million. That's the amount that they get from the state in a regulated way. So all payers. And if they manage their defined population to less utilization, they still get the same payment as a hospital.
Therefore, they make more money.
Therefore, they make more money. They have less costs. They're getting the same global budget payment. It's an example of this kind of furthest down the road type of payment, population health payment.
So that's the category 4 payment, which in your report you are saying that we are headed that way. We are not there yet, but we are headed that way.
CMS
and our system needs to be ready for that.
Exactly. CMS has stated, and that's still a general policy, to move the healthcare system down the road from Category 1 to Category 4 over time in those type of payments. So
explain the timeline of going from Category 1 to Category 4 in multiple healthcare systems in a single community. In other words, you can say, okay, JPS, you have a connection system, and we're going to pay you to manage that population. But there's crossover of that population with other healthcare systems in the county.
Yep.
How does all that work out?
Yeah, with complexity, no doubt about it. Yeah, and that any given health system has multiple payers, some of whom, even if they're Medicaid, they're managed care Medicaid organizations, and each one has a little bit of a different payment to bring to the table. So with complexity, certainly having that in Maryland as a state-regulated piece for all payers made it possible to get there in a more accelerated way. The other way to get there, which is suggested here, is for the provider organization to really become over time, a health plan or get the infrastructure in order to do that, to take on a population, take on accountability for that population in terms of both quality but financial as well.
Are you referring to the model similar to what THR is doing with Aetna? That accountable care?
Yeah, so
one model is a accountable care organization. I'm not sure about PHR and what they're doing, but yes, in working with partners, potentially payer partners, to provide the administrative infrastructure to do some of those pieces. But yeah, there's
Probably
different
even
ways to
favor
get there,
Scott
for sure.
White in the connection there, what Scott White brought to the table.
There's definitely various ways to get there, but to be thinking about taking both quality and financial accountability for a population and figuring out how to build that capability within the organization. Further.
So again, we're in a continuum, and we're at, category 2.
Category 2,
Right.
mostly, yeah.
So
And it seems as the population is more mobile, that seems to be even more complicated. I mean, I guess I'm having a hard time wrapping my brain around how you just would do it in Tarrant County.
Well, with technology,
the
I
multiple
think that
hospital
makes it.
systems.
Yeah.
And then the mobility of the population, you just don't have that many people that stay in the same place as long as some of us have, I guess.
Well, in a way,
Especially people like Roy.
Don't we do that to a certain extent now with the hospital? I mean, with your clinics trying to begin to get treatment at a primary care location and to manage the health of that individual so it doesn't show up in your emergency room unless he's involved in an accident. So I know there's a bunch of different ways of skinning this cat on this particular issue, but I think that's what everyone is trying to move to is to manage in a way that you keep that individual as healthy as you possibly can.
Well, and if I may interject, the great part about a system like that is if you are allotted $400 million for your health care and you only spend $300, you're $100 million to the good. The flip side of that is if you're allotted $400 and you spend $500, they're all real sorry you don't get any more money. So and hence you see hospital systems merging, coming together, because bigger must be better. If we're small and we can't make it, we'll get bigger. We'll make it up in volume. Heard that quote before. We'll make it up in volume. So to me, the other person who becomes real unpopular in this sense, and I've seen it, is the patient with the chronic conditions who keep bouncing back to the hospital. We don't want any of those. We want you in, you want you to do your stay, and do not bounce back in 90 days because the hospital will be penalized for that. Hence the other motivation to try to get people healthy and keep them healthy. But God help the poor individual who has diabetes with heart disease, who has chronic kidney failure, and dadgum, those things just won't all go away. I'm sorry.
No, you're absolutely right. And risk stratifying and defining that in some way becomes an opportunity for JPS to show its light that you are taking on complex patients and doing that well if you can get that risk stratification correct.
Right. And
Committee, are we asking Lori to make some adjustments to the text here? I think that's what we're trying to drive at. On this particular issue.
On these categories?
Yeah, is there a recommendation from the committee?
It's so crystal clear what we were talking about.
Yeah. It is. But is there something we specifically want her to put in the report about this?
I'm going to change some of the language around value.
But make it a little bit more for the label. Yes. I mean, I read it and I really try hard to understand. But then English is my second language, so I decided to bring it up to make sure.
You made your point.
I don't think it's just
you made a good point, sir. All right, Lori.
Okay, so let's move on. So those are the national trends. Was there a question?
There
Becca?
was a
Yes.
question from the audience.
Or a comment?
To the microphone.
I noticed that
State your name, sir.
I'm Joe Lukaska, and I practiced in family medicine for about 40 years. And the value-based care, for example, nobody's taking into account the bureaucracy that's involved in that. The contract that physicians will have to deal with for MACRA is 2,900 pages, okay? That's the first thing, and a lot of the MACRA value-based care is personal, what you tell them. So you can fake it. you can fake it. There's so many flaws in this, and if you look at the bureaucracy that's going to be involved in trying to manage a value-based thing like MACRA, I think you're going to come out on the lower end of the. I think you're going to lose money rather than save money. I have other comments, but that's. I mean, I noticed that purposely not putting in MACRA is kind of telling to me, like trying to hide it.
Oh, I don't think so. I think we were just talking about trends, things that are coming. We're not, proponents or opponents of it. I think we're just saying what's a trend nationally, and it's here, And if you don't prepare yourself for it, then it's problematic. We want to see JPS thrive and prepare itself as best it can to benefit from a system that's on its way. So
is MACRA?
But I hear what you're saying in terms of difficulty in the transition. There's no doubt that it's challenging.
So is MACRA a set of federal mandates that we have to follow and we don't have control over, or?
That physicians will get more or less payment based on their performance now, and performance in this year, in some future years, their payment.
But who dictates that?
Federal,
The federal government. Okay, so if we want to receive money from Medicaid, then we have to play ball whether we like it or not, unless we can get Congress or somebody to intervene, right?
Yeah, or somebody.
We may need to send you back to the House.
No, not that.
You're ready to work on that again, right?
Yeah.
And the MACRA is Medicare, but it's a example of that kind of movement along the category of payments that's also happening in Medicaid.
Okay.
I'm a little concerned about the time, so we're about halfway through the meeting. So I'm going to try to pick up the pace a little
Yes,
bit.
please.
So we talk about health status. We pulled out the key pieces here: obesity, diabetes, infant mortality. We're going to update that with the new data. Immunizations, behavioral health, substance abuse, and we talk about dental access and primary care access, and that's difficult for low-income folks in the county. Any comments there? Concerns about that piece?
Was there anything addressed in the discussions prior that addressed the dental issue? I mean, I read it in this report, and it basically says we're
Going to put them in the clinics? Yeah.
well, it says we're basically 40% of it, 50% of adults have no dental care,
Yeah.
have not seen a dentist in the last year.
Right, that's self-report, yeah.
Yeah, so.
Right, it's a major issue here, and it is a major issue nationally, and so.
But it seems like this report says it's a bigger issue here in Tarrant County than nationally.
Well, yes, it is, and we had that in the report since the beginning. And in recommendations, we talk about integration of oral health to the extent possible in community health centers and other places. But it's a real challenge here.
So that the clinics become not just a specific, if you've got diabetes, that you're just not dealing with, but if you've got a toothache and a stump toe.
Total service.
There's oral health prevention work that can be done by primary care providers as well, looking at prevention. But you need to have a dentist to refer to, and so beefing that capacity up
Pastor,
countywide is a big issue.
You wanting to raise that?
No, I'm just, my
You
wife's
hadn't noticed it before.
in the dental end, and that's an issue for her.
And you're right, we haven't talked about it.
I don't think it's been addressed. I really, when I read that here, it kind of jumped out as, I don't know that we've really addressed that.
Well, we did, it was a brief discussion of it, I think, when we got to the clinics part, because I think someone asked the question, so what are we doing? Are we just doing ambulatory care? And then someone said, no, we're going to do dental as well. So it just didn't. Integration. We're big on integration.
I think is just a point. But.
Yeah. Okay.
Okay.
No, yeah, I'm glad it's in there.
Okay.
Okay, the next section is demographics and population projection. We've talked about this quite a bit. Talked about general demographics and then projections. And we look at how low-income populations are increasing over the next 20 years. We mapped low-income populations currently. And then we talk about aging and increasing diversity of the population, and that the youngest and the oldest age groups are increasing most rapidly, and that has implications for maternal child health and management of chronic conditions, long-term care services and supports, and end-of-life issues. Comments, questions about that? Okay. Then we have the community voices section, where we did focus groups and community forums. We identified themes that emerged from those. We also have themes that emerge from interviews with heads of hospitals, both medical and behavioral health hospitals, psychiatric hospitals. And I think that was, and then some comments from JPS as well. JPS Board of Managers. And I know we've reviewed that several times, so maybe we'll move on to the implications of the population growth on the facility. So Greg is going to take over at this point.
All right, and I think we're certainly behind where we intended to be, so I'll go relatively quickly. These are all numbers that we've reviewed before, but at the same time, have you look at them for how they are communicated on the page here, and if they're communicated well. The first is primary care, where...
What page are you starting?
Let me get that here.
26.
26, yeah.
Page 26.
Primary care workforce.
I see Lori was going left to right. I was going back trying to find it. So what we're showing here is that currently 26% of the capacity within JPS is to be able to serve 26% of the focused population. So 378 FTEs needed there. There's 98 FTEs of capacity, and 26% can be met. Also saying that the county as a whole does not have enough primary care. And then that's table 1, basically showing that the FTEs in that focused population, how many are needed. And then in the text saying it's that 26%. And we move down to table 2, which is really showing at 26% how much primary care capacity would need to be built, and to get slowly up to 50% over that time period, how much primary care would be needed, primary care capacity. And then table 3 translates that into health centers. We take that health center piece and basically are saying, based on workforce and other, building these buildings, that having those 4 to maybe 5 health centers over 5 to 10 years, so spreading that out a bit in terms of a recommendation, is what makes sense. Any thoughts on the words here or the way that it's presented? And this really ties back to earlier recommendations about primary care being the foundation and being preventative, and then it's going to go forward into the hospital piece and being able to reduce the amount of hospital beds needed per population. All right. And then there's pages here that are giving geographies. So talking about the criteria that were used to define those geographies, which is the amount of population in each, the target population, and the health centers and primary care providers already in that geography. So using that as the base criteria, and then other qualitative criteria to define these 4 geographies. Any comments on that? And then also in here, which Lori was alluding to, is the behavioral health integration and the oral health integration within those primary care health centers. That's already going on, and that would be envisioned in future health centers as well. All right. We're on page 34 now, so flip through all of those site recommendations. Page 34 is specialty care, and taking the same kind of view, the population of focus, and saying the capacity that JPS currently has to bring to bear on that population. There is a deficit in specialty. It's different across specialties, from 6% in dermatology to 72% in infectious disease, but is around the same level as primary care at 27%. Making suggestions in this paragraph, not only does specialty care need to be reinforced, but that needs to be done strategically, thinking about which specialty care makes sense, so it's not across the board, and that things other than just building up capacity do make sense here, like new facilities that allow for better efficiencies, but also ways of delivering care like e-consults, which decrease the amount of specialists needed to get the same amount of services for a population. Also suggesting in here the ambulatory surgery center and the cancer center moving on site.
And you see our recommendation at the end of it.
Yep. Committee unanimously recommends, as on page 35, the construction of 4 community health centers in the next 5 to 10 years is feasible, on-campus clinics and support services, including on-campus ambulatory surgery centers. All right. So then we move to the main hospital recommendations. Some complexity that we've already gone into, which is moving from the current kind of situation where there's enough beds in the overall county, defined by the 50th percentile in the Dartmouth Atlas, but not enough for the population of focus, and different ways that we see that, and ways of defining that. One is to say, we know this population is going to grow. What would it take to take care of that new population? And that's 648. So that's one way of looking at that. That's in table 4. That one way of looking at it is the new population that's going to be growing. How many beds would be needed to take care of them? Another way of looking at it, which is what was brought here forward as well, is how much of current resources is JPS using within the hospital and staff, et cetera, to take care of the population of focus? How many beds is that? How much does that serve the current population's needs? And bringing that forward over 20 years with the knowledge that you are going to go down in the number of beds that are needed for that population. How much? Well, 2 numbers. One is 18%. That's from the Dartmouth Atlas, saying you're going to go from the 50th percentile to the 10th percentile. So really becoming, at least at current numbers, ahead of the pack. So 18% or 10.6, basically a number that was used previously and really focuses on JPS's ability to bring down length of stay. So kind of your own internal resources being able to reduce that hospital bed need. So that gives you a bracketed range of 594 to 664. And then this goes on to say why the current facilities just are not okay to go forward with, and ends with the recommendation for 676 beds.
Everybody remembers our discussion about this?
Okay. And part of that is it comes in units of 60, so that's why the 676. Any questions or thoughts on that section? Excellent. Page 39 begins the behavioral health facility. And here, laying out what we've gone over before, which is that there is a very high need across the population for behavioral health beds to meet the overall needs of the county. But bringing that down, as the committee has said, through outpatient services and an integrated system for delivery of behavioral health could bring that down to a much lower number. And that JPS would not be meeting that overall need that's therefore defined for the entire county, but 50% of that. So that brings you to a number of 516 as kind of the number that's there as what's needed for the overall county. Goes from that number and discussing that and what that means to the reasons why the existing facilities are not adequate. And some of them are similar to the acute care hospital, and some of them are particular to that campus. And then goes to the recommendation, which is 298. And so here we see the sentence, this number was derived by taking the 2014 Brodus Blue Cottage recommendation of 198 beds and the committee's decision to select the top number of beds achievable given population need. This is consistent with 2 additional completed floors of 100 beds, 198 plus 100 equals 298. Okay with that language?
Does that work for you on the recommendation in blue?
This is page 40 on the kind of boxed in. Because that was
we still good? Everybody happy with that still?
With that kind of 298 as being decision to select the top number achievable given population need. Excellent. Okay, page 41, we really get into the overall recommendations now, coming back around. And here we're talking about, from an earlier comment, of not having these as 1, 2, 3, but rather kind of bullets. So not saying that these are necessarily in priority order, although if we want to talk about reordering them, that would be possible, I think. So first is the ambulatory care infrastructure. That you are saying there is a continued need to shift from inpatient to a foundation of primary care, and planning to double the capacity for primary care over the next 20 years. And then more specifically, those community health centers that we define, those 4 community health centers. And then the countywide outpatient behavioral infrastructure to really across the county have the emphasis shift from that hospital care to an integrated outpatient delivery system, and to have planning around that, what that should look like, including how substance abuse is dealt with within the behavioral health system. Then the main hospital, which we just went over, 594 to 664, and does here mentioned a recommendation that JPS partner with any new entrants in the market on the trauma center. And then the behavioral health facility, essentially saying what we had said before, that it's not adequate, and strongly recommend replacement with that sized hospital at 298. I'm going to switch over to Lori here to finish out these.
I think this is a really important section.
Switch to overall recommendations. They just flip to that section. They flip to executive summary. So I think these 2 particular sections need to be really strong. So any comments you have on these, we would appreciate. Okay, where are we? Workforce. Okay, so Greg just talked about the facilities and the need for expansion, so we have to talk about the workforce. So we talk about JPS as a vital contributor to the education and training of the county's future healthcare professionals, that you are federally designated, health profession shortage areas and medically underserved areas, and that will worsen as the population expands unless there's a concerted effort around workforce development, and that the committee recommends a county-wide planning effort related to graduate medical education and other health professions training and recruitment strategies to meet those needs. The next is integrated delivery system. So again, talking about the sustainability of JPS, requiring a strengthened integrated delivery system. It is an integrated delivery system in and of itself right now. It is a health network, and it is becoming more and more well-positioned for alternative payment methodologies as they strengthen their population health and care management programs and other programs. The next, and then we talk a little bit about considering possibility of connecting further between health systems around populations in need. The next is elder care and looking at the recommendation for JPS to continue to develop capacity in geriatrics, in primary care and behavioral health and inpatient, and work with others to ensure a strong infrastructure for folks as they get older. The next and final is the prevention and social determinants of health, and we've talked about that quite a bit. We focus on a strategic alliance between JPS and Tarrant County Public Health to strengthen that, and focus on countywide prevention planning and implementation, perhaps around things like diabetes, like preterm birth. And we also recommend that Tarrant County, with support from JPS, kind of systematically address social determinants of health through policy and other efforts to create those healthy social and physical environments. So that's pretty much how we conclude.
Yeah, Laura, may I ask a question? The numbering, so we have 8 recommendations. Does the numbering indicate priority?
It doesn't mean anything.
No, okay. But then I would
We just put the facilities together and then we put
bullet as opposed to numbering, because you don't want to, I don't think we want to get into that.
And I just want to say again, I hope you'll put some predicate language in the top there, really showing that we're not detached from reality. We understand there are fiscal limitations and there's all sorts of, we're just pointing out things we saw as opposed to things we're recommending. I mean, we're not
Okay,
recommending
based
you do all
on
this.
need, right, carte blanche, right.
Because
So
then
I will put that
commissioners
in
think we're
the,
crazy, giving them recommendations to do all this, and so they have to understand.
Too late for that.
GK, may I do something that are there others from the community that wanted to make any observations before we kind of wrap this up? We're going to have another bit of discussion, so, the community person I always want to like to.
Right, let me make one comment. I think that, first of all, Dee, your comments, I think those are really good comments. One of the things that we may want to also consider in this report is mainly a 3 or 4 paragraph conclusion, kind of summing it all up, because it kind of leaves us hanging. And,
right.
And I think that what we talk about in the executive summary, we've talked about fiscal constraints, we've talked about a whole bunch of things, but we reiterate that in the conclusion also. So it's a beginning and it's an end. It's bookends, basically. And when I read this, it was just something where that you were looking at, okay, so that's all the information now. Where's the wrap up, basically? And I didn't see that. So we might try to work on something like that.
Guys, in our waning minutes here, I really wanted to open the floor. They asked me the explosive question the other day, so how do we do this? And we had a kind of a robust discussion with the staff. And one of the things that struck me is all of us have had reports done. And what happens to them most of the time? They sit on the shelf. And we thought, I just kind of thought that this would, if we spent this time looking out for the health outcomes of our county residents, that, to me, we want to see some legs with this. That this is not a report that we do the obligatories to the Commissioners Court, to the Board of Managers, and our hands are washed. In order for this to take the life that it has to have toward implementation, and you're absolutely right, Dee, we can't do all of this, but that we can, I think it is up to us as a committee to help our citizens understand the magnitude. And so we thought about a call to action that would kind of emphasize, why are we doing this, the why question. I was telling them, I attended Jarvis Christian College, and I had a French professor, Dr. Vorsick, who said everything has to be clear, clean, and precise. And so if we could come up with something on a 2-pager or 5-pager, as you suggested, Commissioner, but something that the average citizen can understand, not only the impact, why this is important, the demographics, our need for, with those demographics, the population increases, why are we going to have more physicians and nurse assistants, why this is important to me as a citizen, so they can own it and understand we have to plan for this and be proactive. I don't think we then have to sell a bond program, because people will see it's in their interest, in their own self-interest, to be supportive of health care. Why preventative health care is important. And so I just wanted us to spend just a couple of minutes with your suggestions, and GK, if you'll help me to understand, what do you think we can do now? Our report, let me just say, this is not the last time we'll see it. Before it is actually published, Candace, we will have a chance to preview it again.
Yes.
So any edits as you go home and you're putting it under your pillow and you're thinking, oh, I should have said this. So why don't you just talk to the staff, call, and they will be happy to make any kind of edits you feel are pertinent. And then we'll see it again before it is absolutely released, okay? But now I think is the time for us to think seriously about what do we do with this? And so it doesn't lie on the shelf. GK?
So we talked, in fact, you're absolutely right. We had a robust conversation yesterday. That's a very nice word to describe our conversation yesterday. So when we finish the report, what happens? First of all, we are going to schedule a meeting, a joint meeting of the Board of Managers and the Commissioners Court. And each and every one of you will be invited to that. And we're going to ask the 2 co-chairs to present the final report to the court and the board, and have I hope, a fairly lengthy and detailed conversation. I think, Commissioner Wood, we saw part of that conversation already in court when we picked up the HMA and the coming recommendations. I tell my staff that, and we've got great staff that have worked on this, both from our office and JPS, that this is only the beginning of this. There's absolutely no way that we can take a report like this and showing the needs of what this community needs and just simply say, okay, we've done our work and it's time to go home. We're talking about the fact sheets, which I think that more that I thought about it last night, quite frankly. I think that there's some really good ways that we can go ahead and let me just speak. Yeah, sure. Sorry about that. There's ways that we can make that very easily readable. We're talking about maybe some presentations, but really when it comes down to it, I know that our court's going to move forward on this because there's a real commitment on the court on this. But they and the Board of Managers can't do it by themselves. When you look at this group here, and I've made these comments to the Commissioner's Court, we have a very good group of diverse individuals. We do. Think about what you do for a living, your thoughts, how you see the world. And when we can get to a point where that we have 12 individuals that can come together and unanimously support 5, 6, 7 major recommendations, to me, that speaks louder than just about anything else. So it's going to be important that as we move through this, that we begin to tell our stories and take this out to each and every one of our communities to make sure that people understand it. And we need to make sure that the presentations or the message that we have is an understandable message. I mean, it's absolutely clear. It needs to be clear and concise. And so these are the type of things that we're going to have to focus on. When I say we, I'm talking about the people in this room. It's not just staff. It's not just this board, but everyone that you see in this room and more. Because if we do nothing more than file this report and it sits on a shelf, then we have failed. It's as simple as that. We have failed because we all know that there is a real need in this community. Two-pronged. We've already looked at how the forward-looking health delivery systems need to look at. New paradigms that are going to be created, have to be created. And at the same time, look at the JPS's role in that and just the physical infrastructure of JPS. And you all have taken the tours, and it's so lacking. One can't do it without the other. It has got to be both, or you're not going to be successful. And so when we look at this and we look about how we move forward, we want to do that aggressively. We came up with a term yesterday, a call to action, and in reality, that's what this really is. But it's not a call to action for someone else to do. Mm-hmm. It's a call to action for all of us to do if we're going to be successful. And our goal from the very beginning on this process was to be successful. So.
Well, and it's going to evolve into different phases. Randy and I, early on, he and I were just talking, and I said, Randy, this has got to be a communications phase. We've got to be able to communicate this to people. So we can't just say, okay, we're going to do a little press release and put it in the Star Telegram and expect that people are going to say, oh, what a great commission and what a wonderful report, a great thing to do. Most people won't even read it. It won't faze them. So we talked a little bit. Remember one of the meetings I bought the Levita newspaper? That is a local African-American newspaper. And when it had John Peter Smith, JPS Connects, that resonated, and that goes to people, everyday rank-and-file folks. And so that's where I'm hoping that we can get to the point that get the message, the call to action to the rank-and-file, that preventive health care is essential. If we're going to have good health care in Tarrant County, we've got to have a strong emphasis on prevention. I use, maybe a little awkwardly, the example of what the mayor's done with bicycles. In the District of Columbia, I hate bicycles because they're an impediment to your driving. They don't abide by the same traffic rules. Right?
And they do here?
Well, you don't see us. They're not as heavy. But in D.C., I could, oh my God, it is maddening what bicyclists do. But my point is, she has made bicycling a call to action. It's a charge. You say, well, I had never thought about buying a bicycle to exercise. I am slightly considering it, slightly. But my point is, she made the case for it. And if we don't make the case for health care and preventative health, and why it is important that we have a behavioral hospital, and why we need more doctors that get trained here but stay here. If we don't make that case, ladies and gentlemen, we do fail. And so we're just trying to figure out what mechanism, how do we do that in a way that involves all of us. Right, sir?
I agree.
Okay, so we're gonna get out on the stump. But, no, just something simple that we could do a PowerPoint. If you're at a neighborhood meeting, that you can, the pastors could do it at their churches, amen?
Do that.
That Roy can do it when he goes to visit with his doctor friends at their, at your meetings.
I have no doctor friends. Forgot to say.
When you're out on the golf course, take your PowerPoint out, come to the ninth hole for a break, do it. But I say that in jest, but I'm saying it's going to take all of us to make sure our citizens understand why this is important. That's the whole point here. And so if you've got some suggestions of how we can do this in a way that makes sense, Commissioner, we're open, aren't we?
We're wide open,
Thank you.
including your pocket.
Well, I don't have pockets. Okay. GK, anything else?
I think our next scheduled meeting is supposed to be September 12th.
12th, yes.
That will probably be our last meeting before we do the final, we approve the final report.
Okay.
And so, you can tentatively put that into your schedule, but that may be subject to change. We want to make sure that the document is in a form that you all think is appropriate. So we'll get back with you as far as that date, but we're going to be working on this over the next couple of weeks. Hopefully we can get it to a point that you all can at least have your final mark.
I think GK said something the other day on our conference call that was very important, committee, that I want to repeat for his benefit. He says it is important that this document be a product of this committee. So your input, what you did today, making those comments, that's key. That makes it our document. That makes it the committee's document. And as we've had observations from citizens, and we want to thank these folks that have sat through this with us, through the deliberations. We really appreciate it because it's when you know that you're in a foxhole, you want to have a lot of company, and and we appreciate that. And your comments and thoughts are well taken, and we appreciate it. But this is our document, and so we want to make sure that everybody has the input. If you've got something that comes up later and that you feel that's important, I think it's important that I touch base with them. Call Candace and Lori. They'll be happy to help. Anything else for the good and order? September 12th.
I have one question.
Yes, sir.
For Lori. There was a longer report, like 256 pages. What's the difference between that report and this report?
This is short.
Condensation.
What do we call, which one is both of them the official report?
I think you wanted to have them
What
appended.
we're going to do, HMA has, and you all receive those reports and you analyze those. And Cumming has actually a report probably much larger than that because it's a facility report. We're going to attach and make that part of this report.
Okay,
So
like an exhibit almost, okay.
yes.
But this report really has your processes in it. I mean, ours stopped at a certain point of our research, right, and our recommendations, and then you took the recommendations from HMA and Cumming. You thought about those, you deliberated about those, you viewed the facilities, and you came up with your own recommendations, some of which are different than ours. So.
And that's important because it's the recommendations of the committee. It's not the recommendations of the consultants.
Yeah. Okay. Ladies and gentlemen, it is 3:55, and we adjourn. So moved.
My friend, it's been fun. Say anything about this. Right here on